Hello, I'm Dr. John Kruse, and welcome to, sorry, I'm not sure my microphone is on, and I'm going to adjust that right now. Hello, I'm Dr. John Kruse, and welcome to today's question and answer session, So I'm open to questions on the videos I released this week. I'll summarize those in a minute, or other ADHD topics or other general mental health questions. As usual, the information here is provided for information only. These are not specific recommendations for your medical conditions if you have any. But you can hopefully take this information to your treatment team if there's something that's relevant that I talk about. And feel free to share this channel with your providers as well as your friends. Two other things. So last week, the sound cut out at the end. I am completely dependent on Mr. Elon Musk here. So the only internet connection in this part of rural Hawaii is through Starlink. So hopefully the system will behave. I will say that it's rather interesting that the tech titans who don't seem to have a perfect track record with their own products are the ones who we have entrusted to taking care of the government, since I guess someone considers them infallible in their judgment and how well everything gets executed. Anyway, enough political commentary. One other thing before I launch into the summary in today's questions, there was a question last week or a comment that someone had seen it repeated a couple times, that 50 to 60% of your body's energy uses are devoted to your brain, and it only makes up 2% of your body mass. My initial reaction, I don't think I stated it clearly, strongly enough, but when I went back and checked, is that the real data suggests closer to 15 or 20%. That's still disproportionately taking 10 times as much energy per mass as other parts of your body, but it's not the major consumption of glucose or energy in your body is not the brain, but 20%, 15% is a big chunk of it. So the two videos that were released this past week, one was on Qelbree or Viloxazine, and the other was on which drugs worsen ADHD. So regarding Qelbree or Viloxazine, and it's not to be confused with vortioxetine, which is Trintellix, or Viloxazone, which is Vibrid, which are approved for depression. So Viloxazine's been around for more than 40 years. It was first used as an antidepressant in Europe. It was never approved for that use in the US. It, at that time, was thought to be a pure, clean, simple norepinephrine reuptake inhibitor. It never was a big seller, not because the studies did show it to be effective. It just wasn't ever very popular, probably because it was in a class all by itself, and doctors tend to be more comfortable if things they're using are familiar and alike or akin to other things they're using. It was then in the early, I think, 2000s, briefly licensed in the US as an agent for narcolepsy, helping keep people awake during the daytime, and then restudied, relaunched as Qelbree for treating ADHD. There's a moderately considerable body of evidence that it is effective for ADHD. It seems to help with inattentive as well as impulsive hyperactive symptoms. Its effect size is comparable to other non-stimulant medications for ADHD. How it's working is not clear, so there's increasing evidence, at least in animals, that it has some significant serotonin subsets of receptor actions, 2B antagonism, and serotonin 2, I think, C agonism. And at least in rodents, which aren't always a good indicator of what's going on in people, it's boosting dopamine, norepinephrine, and serotonin in prefrontal cortical areas. And in general, it seems to be better tolerated by many people than Strattera and amoxicillin. The second video topic was on which drugs worsen ADHD, and along with many of the topics we discuss here, there's not a lot of rigorous data. Probably the most researchers study is on stimulants, actually, And I think it's particularly when the dose is not right, when it's too high, stimulants can exacerbate distraction, irritability, and other symptoms of ADHD. Clearly, if sedating medications are too high, particularly benzodiazepines in this era, that can work counter to some ADHD medications. And as some of the viewers pointed out to the channel, certainly alcohol and marijuana for many people can interfere with or seem to impair ADHD, increase ADHD symptomatology, cause greater impairment. So that's what I have to say. And again, you're welcome to ask questions on those and on other topics. And I see there's already several questions coming in, which is good. So James, hello again, asks, is green tea good for ADHD? So that's a good segue to, I do have a talk on L-theanine on this video channel. So green tea as opposed to black tea, and we're making generalizations here because it depends on the tea plant, it depends where and how the tea plant is grown, it depends on the genetics of the tea plant, and the green versus black is largely the processing. Black is more oxidized, but as a gross generalization, black teas tend to have more caffeine. So caffeine is one stimulant that at least has some benefits for some ADHD symptoms. And the other component we focus on, and not that these are the only two, is L-theanine. So L-theanine in several studies seems to help caffeine be more effective. It may actually boost some of the attention, executive function abilities, and L-theanine tends to be calming, so it may allow people to get a bigger dose of caffeine as well. So there is some evidence that green tea, by that criteria, would be good for ADHD. Tea, as opposed to caffeine, also contains small amounts of theophylline, which is another sympathomimetic. And theophylline actually has a little more cardiac side effects, but it's present in pretty small doses in most teas. So moving on to, hello, Dennis. Dennis asks, before antipsychotics were invented, is it true that psychosis was treated with opioids? So I know they use things like cold immersion baths and putting people into insulin shock, not just for depression, but for psychosis as well. So giving them doses of insulin enough that blood sugars dropped to dangerously low levels and induced a coma. And if the person survived, maybe their psychotic symptoms were milder. I don't know the history of opioids being used for psychosis. I just don't recall coming across that. It seems plausible, but I don't know, just don't know. Of interest, there is substantial research, and this is not sort of in the general domain, of opioids being used effectively for treating depression. And there's a variety of products in different stages of the pipeline, some combining with other agents. It's clearly a touchy topic right now while we're still trying to discourage against prescribing opioids and encouraging people to, in some instances, ignore or deal with their pain without. I think, in my opinion, the pendulum has swung too far the other way in terms of restricting opioid use, but I certainly acknowledge doctors were part of the problem that led to the massive opioid epidemic in this country. So Dimitri says, ADHD is very heritable, and I heard people with it tend to have more kids. Does that mean ADHD will be way more common in the future? Will people with ADHD eventually take over? So I'm aware of research showing that kids with ADHD are having sex at earlier ages. They're having sex less protected and less cautiously. I am not on top of the literature, so I don't know for sure that kids with ADHD have, or young adults, or even old adults with ADHD. I don't know that they actually have more kids. That may well be true. I'm not on top of that. Certainly their indications are having more sex and less restrained sex in general. The other thing, though, that regarding, I mean, the crude summary of natural selection and Darwinianism is survival of the fittest. So you don't just have to breed, you have to breed and make sure your children get to reproductive age themselves. And to the extent that ADHD is substantially connected with reduced mortality, and a lot of that mortality is early mortality, so accidents and suicide before children might get a chance to be breeding. I don't know where the genetic prophecies are right now in terms of greater number. If it's true that they're having a greater number of children, I don't know how that intersects with the greater likelihood of death in terms of predicting whether ADHD genes will proliferate or grow in prevalence in the population. Cosmos Princess is commenting on the things that interfere or worsen with ADHD and mentions that alcohol in any capacity makes their medicine worthless the next day. Is this just an unavoidable consequence of alcohol use with stimulants? Or I would point out that so I have an earlier talk, there's been data since then about alcohol. Alcohol clearly has acute benefits for anxiety, does alleviate social anxiety, does make it easier to socialize, does decrease inhibitions. But most of the longer term data show that it's a horrible match for depression. It's a horrible, anything that quickly alleviates anxiety actually usually leads to a rebound increase in anxiety. It's wearing off. If you're drinking in the evening, most of that wear off withdrawal may be at night, while you're asleep. So you might not notice the increased anxiety, except in the fact that it disrupts sleep. So part of alcohol's toxicity is regarding sleep. If you drink enough, you do pass out. It is sedating, but it disrupts deeper stages of sleep. And even a glass of wine at lunchtime has been found to disrupt sleep later that night. So it's not even the alcohol per se, which is already metabolized by evening. It's something more indirect related to alcohol. So in moderation, and moderation is not much at all, many people can continue some amounts of drinking, but in general, alcohol is not your brain's friend. So Max is saying, responding to Dimitri regarding the ADHD and genetics, yes, we will take over, but don't worry, we'll just forget about taking over the next day. So Max is following up with a question, is there a link between stimulant dosage and the strength of a crash from the stimulants if one is prone to those? Again, I am sure, if I can be sure of anything, I have not seen any data at all related to that. And part of it is, how do you measure the severity of a crash? Some of this is subjective, and particularly if we're working with ADHD people and what's going on now is everything, and time is either it's now or not now. That would make it even harder to use a scale to remember, was this worse than the crash from half your dose 2 days ago? But at least at a pharmacologic level, it would make sense that a higher dose might lead to a greater crash or diminution. And again, one of the things to remember with stimulants, it's not just how big the dosage is, it's how quickly, particularly drugs that are affecting dopamine, are how quickly that's changing at the level of the receptors. Piotr Wolanin asks, assuming a small dose, is Vyvanse simply time delayed dextroamphetamine with a slightly broader concentration peak? Yeah, so it's the same. The active ingredient is dextroamphetamine. It goes in more gradually, and for many people, it's sort of a more optimal rate than any of the slow release designed packaging manufacturing to ensure slow dissolving. But yes, it is the same medication. Candido asks, mirtazapine with antagonism of alpha-2 receptors makes worse ADHD behavior. What is the comparison with guanfacine? So again, there is a very limited bit of research suggesting, at least in some people, mirtazapine can have positive effects for ADHD, and despite some of its direct action immediately as an alpha-2 antagonist, I think a pre-receptor alpha-2 antagonist, it does seem to boost both norepinephrine and serotonin levels, and boosting norepinephrine levels is generally beneficial. I don't know of any direct head-to-head comparisons between guanfacine and mirtazapine. So again, yeah, I'm not aware of any direct comparison. Again, with guanfacine, either immediate release or extended release, there's, I'd say at this point, a fairly extensive body of research showing efficacy for ADHD, but it works slowly. I don't know with mirtazapine in the individuals who have shown some benefit, and again, there's not a lot of research, whether that's a slow effect or an acute effect. So part of the complexity of our brain and our neurotransmitters is that acute immediate effects don't always tell us what the longer term ongoing effects will be. So I mean, with depression, many of our antidepressants are serotonin reuptake inhibitors, which are initially boosting availability or extending the length at which serotonin can act post-receptor, effectively boosting the amount it's acting. But there are also other drugs which tyenapine, I'm butchering the name and not remember it completely, not approved in the US, that seem to have actually reverse immediate action, but also have efficacy for depression. So acute immediate effects don't always tell us what the ongoing effect on different receptor systems have. James asks, have I thought about making book reviews or maybe a video tutorial on how to read scientific papers, how to understand the statistics in scientific papers? No, I haven't thought about that. I guess, I mean, part of why I haven't thought of it, I guess some of it is in my toolkit or skill set, but I don't think they're necessarily particular strengths I have. It's just one thing I do or read. I do think there's other people out there on the internet who are more generally talking about how to read scientific papers, and who may, certainly with statistics, I am not an expert statistician. So for example, with some of the discussions about whether cigarette smoking during pregnancy or cigarette exposure in the first, particularly during pregnancy, there's a fairly contentious and I would argue undecided debate as to whether some studies find a connection, others think the connection is dissipated or completely gone when you control for other factors. My statistics aren't adept enough or skilled enough or sophisticated enough, I guess is the best word, to sort out which side of the answer is accurate there. So, and in terms of book reviews, so it looks like there'll be plenty of questions, but one of the upcoming videos, I have sort of given my review rebuttal summary to the New York Times article on Are We Thinking About ADHD All Wrong? Russell Barkley has done a 4-part series on that, videos on that, where he goes into good amount of detail and precisely skewers many of the factual inaccuracies in that paper and the distortions. I do have differences with Dr. Barkley on the overall impact of that New York Times article, or intention, or whether there's benefits to that. So Beth LM, I'm not going to ask what are my thoughts on the studies about psychostimulants, modafinil, atomoxetine, and guanfacine impairing bone cell differentiation and MSC migration. So I'll just plead ignorance on that one. I don't know, and I will write it down. And I mean, what I would say is I'm aware of, things like SSRIs, I mean, more particularly benzodiazepine, are associated with falls and fractures. And I don't think we have any evidence with stimulants leading to more fractures. So there may be some silly, I'm trying to write things down while I'm talking. Yeah, so right now, it hasn't risen to my level of being something of concern. I will try to check into it to see what we know. And if there's enough to talk about and present, I will present. And there's a plane flying overhead right now. I don't know if that's about to choke. So thanks for bringing up the topic, Beth. I will look into it and report back if I find anything, but I don't know enough to comment. So Max is forwarding a comment from the Reddit channel by Significant Club. I think that's what it says. I have 2 children, a 13-year-old diagnosed with autism and a 9-year-old with ADHD, but I think the oldest could also have ADHD in addition to autism. He doesn't like to get to bed early, drinks a lot of coffee, changes from an activity to another in random ways, very inconsistent energy. How to distinguish between one or both of ADHD, autism, what behaviors to pay attention to. So it's a good question. I do have a video on autism on this channel, and the focus of that is differentiating between the two. A couple things to point out to begin with. There is a significant amount of genetic having ADHD, the genetic contribution to ADHD, some part of that is shared by depression, schizophrenia, anxiety disorders, autism. So there's a lot of general, you're more likely to have any mental health condition if you have certain variants of these genes, but there is more overlap between autism and ADHD than between many. So there's the two of them do cluster together. We know that having one makes you considerably more likely than the other. So it kind of works both ways. If you have autism, you're more likely to have ADHD than the general population. If you have ADHD, you're more likely to have autism. And I think even though ADHD gets a huge amount of flack for being overdiagnosed, I think we're still missing. I think underdiagnosis is still a bigger problem with ADHD. And I see increasingly, on the other hand, I see what I think is overdiagnosis of autism, and particularly people with social anxiety and other conditions, including ADHD, being told they have autism. So the central feature of autism is problems with social processing, and it's not an aversion. It's not being shy or awkward or being uncomfortable. It's how the brain is actually interpreting, understanding, grasping social interactions. That can lead to an aversion to social interactions, sort of secondarily. Second, autism, at least in the official definitions, has some amount of what are called stereotypical behaviors, so repetitive behaviors that are being executed in exactly the same way. So it can be hand flapping or head rocking or banging. And then the third general cluster that's in autism is specific interests that tend to be focused on the details, or I will say superficiality of the interest rather than getting at the gist or the essence of that thing. And so, I mean, a common one is memorizing train tables or subway routes and not having much understanding or grasping of where any of these places are, or what the subway is, or what's going on there. So in terms of differentiating the things you are describing with this, inconsistent energy, changing attention, benefiting from stimulants, caffeine being a stimulant, erratic bedtime, all of those to me more strongly suggest ADHD than autism. I mean, the other thing to know is that ADHD symptoms, when they're in the setting of autism or not, do tend to respond to medications such as stimulants. With autism, although there's some experimental work on a couple different medications, and there's some evidence that risperidol and Abilify may regulate some of the aggressive or agitated aspects of autism. We don't have a very good handle on medications that provide substantial symptomatic reduction in autism. So again, if you're missing ADHD, I would argue that in some ways is more critical because there are treatments that are likely to be helpful. And so you're welcome, Piotr. So Cosmos Princess asked, for someone with ADHD, should they make a daily or weekly schedule? So one of the videos that was just released on my channel a few days ago. So I think in the first 5 videos I released, so it's an older one, the sound might not be good quality. It's on scheduling for ADHD. A month or 2 ago, I was interviewed as part of the ADHD Entrepreneur Summit, and the topic of my talk was schedule is your friend. This is, again, specifically for people with ADHD. It's hard to do, it's challenging, but part of the challenge of ADHD is less ability to construct the structure you need to make your day work well, and a schedule is your #1 friend in that regard. So I could say more, or I'll just refer people to the video, and I think Max will probably pull up a link to it in a second or 2. So Candido is pointing out that guanfacine antagonizes alpha-2 receptors and mirtazapine has antagonism for them. And that's, again, why Candido is concluding that mirtazapine makes ADHD worse. And again, I'm not even sure that it's the same alpha-2 receptors. I mean, so there are different distribution of alpha-2s, but again, initial action on a receptor is not necessarily telling us what the longer term effects on receptor systems will be doing. So there aren't extensive studies with mirtazapine, and mirtazapine probably has additional actions, as guanfacine might, that may also be relevant. But just because the initial actions in terms of alpha-2 receptor antagonism with guanfacine, agonism activating with guanfacine are opposite directions, doesn't necessarily mean that they'll have opposite effects on living, breathing human beings. And that, I know, is a confusing concept, but I'll stick with that. So Joe Chimes is on generic Vyvanse 40 milligrams, doesn't feel any real effects. Could the dose, brand, etc. be affecting it? I'd like to know if a different med or adjustment might help. So the generic Vyvanse has been out now about 2 years. And when we say the generic, I shouldn't say the generics, I should say generics of Vyvanse. So when products in the US become available to the general generic market, usually, and particularly with a best-selling drug like Vyvanse, it's numerous, and I think in the case of Vyvanse, there have been at least 10 or 12. I don't know if they're still active, all companies making generic products. Now, generic is a prodrug. It's inactive. It's a lysine molecule linked to a dextroamphetamine molecule, and your red blood cells need to split the two apart to get active dextroamphetamine. My prediction was that compared to some of our other slow release stimulants, that Vyvanse should be harder to mess up. And by that, again, I mean it doesn't require having consistency with the coating on the outer shell or a special pH activated substrate or the matrix you're locking it in. The slow release mechanism is the red blood cells, and that's what's going on in your body. So my argument was that it should be harder to screw up the generic Vyvanse compared to the brand name. And mild supporting evidence is among the first dozen or so patients I had that were switched over by pharmacies and not told they were being given generic Vyvanse. The majority of people didn't even know, because I was trying to monitor it and I'd ask them, and I could search online, and because state databases tell you when stimulants are being filled, and you can see whether it's a generic or the brand name. So I knew. So most of them did not notice. Subsequently, I think it's about 2 years now, I have had some people who felt that a certain generic manufacturer was not working as well for them, or maybe working. I can't explain why that would be. I do think in some cases there are placebo effects, but if you're sort of new to Vyvanse in general and just sort of put on 40 milligrams of generic, and that's where you're starting out, my usual response, again, this is not a specific recommendation, but my general medical response is if you are not having side effects to a medication and you're also not seeing much in terms of benefits, it usually makes sense to increase the dose. If you start getting side effects that are causing problems and you're not having the benefits, that's a sign it's not a good match for you. If you start getting benefits and are not having side effects, it often makes sense, unless even at low initial benefits, that seems good enough for you. You could stop right there. More often we do go up and usually see accumulating benefits until side effects are problematic, and different levels of side effects can be problematic for different people. So usually I would go up on the dose. I do have a whole video on stimulant dosing, and that we get fixated on, 40 milligrams a big dose or not? Is 70 high? Can I ever go above 70? The FDA explicitly says their dosage recommendations are recommendations, and that they will not apply to everybody, that they know there will be some people who need higher or lower doses than they recommend. So pay attention to what physiologically we are seeing rather than, and I would anticipate that physiologic effects, more so than absolute dose, in the long run will also predict some of this. So there's a study, and Russell Barkley again dissects problems with that study, claiming that high dose stimulants were a greater risk factor than low dose stimulants or no stimulants for psychosis. It's probably true. That study didn't do a good job of showing that for the way the study was designed. But if you are taking high dose stimulants and not having much physiologic reaction, my guess is that a lot of that is how your body's processing the dose, and it means your body is probably exposed to a lower level. So again, I think even in that scenario, it's probably, again, how your body is handling the dose rather than the dose per se. And Cosmos Princess is adding in, I think specifically to the Vyvanse, or responding to Joe, that they've had varying results with different generics. So one thing to point out, and some doctors are not willing to do this, but you can always request on, at least in the US, on the prescription label, in tiny print, usually somewhere, when it's a generic, it will tell you which specific generic manufacturer. So we'll say lisdexamphetamine by Shire or Roche or Sandoz or Mallinckrodt or whoever's making it. I don't even know if those companies make generics. If you consistently have a bad response to that dose, or you can request, please do not fill it with this brand again, or this maker, generic maker, or if you have a benefit from a particular one, you can say, please fill it with Roche's generic version of Vyvanse. Now, some pharmacies may balk at that. While we're still having some shortages of stimulants, they may say, well, you'll have to wait an additional 3 weeks to get that in. We have to special order it. But pharmacies do have the capability to special order whether or not they have the willingness, and doctors also have the capability of specifying on the prescription specific generics to be avoided or to be fulfilled as. So thanks. So in the chat, Max has included the link to the autism and ADHD video. So Beth LM is saying there's an increasing awareness of Asperger's syndrome and ADHD existing together. Lots of talk of people diagnosed with ADHD, although it's not listed in DSM, and this often being a late diagnosis as the two. So yeah, thanks for pointing it out, and particularly that label ADHD is being widely used. And again, some of the people that have come to me with that label, I have not been able to locate anything that seemed to fit the autism spectrum, that all of what they were describing was ADHD, but there is more cachet, more social support right now. Clearly, there are people that label fits. And I would also say fundamentally, each individual should be able to choose the labels that they feel that work for them. But a separate question, I would argue, is that in terms of a doctor does not need to concur with you on the label you are using, and particularly in terms of prescribing, the doctor, hopefully in consultation with the patient, but is using their judgment. So if they do not think a condition that's likely to respond to a certain medication is involved, then it's reasonable for them not to prescribe that. So Mr. AK asks, is Viloxazine IR versus ER for ADHD? My understanding is that the only form of Viloxazine right now, Qelbree, in the US is an extended release version, but I don't have all the details on that. So I don't think any immediate release version of it's available. And it is recommended as a once a day drug. But I don't know what the pharmacokinetics of the original molecule is and how they're changed or altered by this slow release form or extended release form. So Max is saying that drinking coffee at 13 seems a little young. And Max works with kids, and I haven't seen others that age drinking coffee, but maybe it's a cultural thing. So Max is in France. I think there's cultural factors. I also think there's trends towards, I think when I was growing up, in the dinosaur age, and yes, we did have coffee beans, but we did not have a Starbucks at every corner. I don't know anyone, I don't recall any kids consuming coffee, but I know among my kids' peers, and my kids are graduating from college next week, many of the kids were drinking coffee by middle school years. So again, coffee has some stimulant value. It's more likely to be disrupting sleep. For an equivalent dose, it probably has more negative effects in terms of heart effects and anxiety effects than our prescription more controlled stimulants, but we're usually taking coffee at a lower level. So I think 13 is probably a cultural issue. There is one other aspect. What I was going to say, interestingly, even though we're in the era where there's a Starbucks on every counter or corner top, and we think that we're in the age of gourmet coffee, maybe we're with gourmet, but in terms of average US consumption, way back and I think it's about the 60s, consumption was twice as high as it is now. And as coffee consumption was decreasing somewhat, there was a very prescient psychiatrist, and I have had trouble refinding the article, but I've read it in the last 5 years. There was a letter to the editor. He was actually predicting that ADHD rates would rise because we were self-treating it. So at least in that era, some kids must have been taking it, that we were suppressing ADHD diagnoses by the prevalence of coffee. So it might have been my lack of experience, might have been just a subset of America I was growing up in. So it might have been even prevalent. I wasn't that far back in time. Anyway. So Beth and they're referring to ADHD and autism, but together can cause confusion and mean one or the other has been ruled out. Do you think ADHD is a separate condition in its own right or will be in the future? So there's some of the genetics suggest, again, a close affinity, and there are some sets of researchers or some groups of researchers who think ADHD and AUD are sort of the same at some early point, but that some postnatal, some developmental factors shifts whether some kids will develop an autism picture or will develop an ADHD picture. I don't agree, or that doesn't seem to fit with what I see, but I may well be biased into seeing what I think is going on out there. So clearly there's some recent studies showing patterns of brain activation, what's going on, that there are substantial differences between an ADD and an AUD population, and I don't know how many of them have included a population of people who do fit both diagnoses. So I think, as I've talked about repeatedly, our whole diagnostic system for mental health conditions is in need of revision, and I don't know that anyone would deny that. And how it unfolds in the years ahead, I don't know, and I don't want to predict how specifically it will unfold regarding ADHD or autism or the intersection between the two. So thanks, Max. Max has provided the link for scheduling an ADHD. And Elliot is suggesting to Joe whether they've tried Dexedrine, which is a form of slow-release dextroamphetamine. Their jobs, hello again. Is there a drug that often helps with ADHD on top of Wellbutrin if the Wellbutrin is not enough and can't take a stimulant anymore? I have seen people who are on combinations of things like Wellbutrin and Strattera. I've seen people on Wellbutrin and SNRIs like milnacipran, Savella, or Fetsima, or duloxetine Cymbalta. My thought would be maybe more logical to try something like guanfacine or clonidine, which I'm not a fan of clonidine, but guanfacine, in terms of the initial biochemical mode of action, is more distinct. Again, whether the final biochemical intervention we result or end up with winds up in the same place, I don't know. But guanfacine would be sort of an obvious thing to think of for someone who can't tolerate stimulants or shouldn't be on stimulants. And looking at the time, we still have 15 minutes, good, but a lot of questions, so I'll try to. So Zelda is asking, could I discuss some of the nuances of cannabis among adults on Vyvanse? I feel that my cannabis use borders between recreational and self-medication, but I am aware of mild signs of dependence. So I don't know of any research at all specifically looking at the interaction between cannabis and Vyvanse and ADHD or any stimulants. There's a tiny bit of evidence on cannabis itself, so I do have a video on marijuana, and it's the one subject that I am more open to since doing some of that research. I mean, it is a small body of research, but it suggests that there is some subset of people with ADHD who cannabis is helpful for. It's probably particularly the CBD. Yeah, so I'm not sure what more I can say in terms of, I mean, certainly people can become dependent on cannabis or on stimulant medications. I would just try to, my sort of starting point is mindfulness. And when you are taking your Vyvanse, assuming you may not take it every day at a regular schedule, but even if you are, or when you take the cannabis, asking yourself, what is going on in my brain and what am I feeling? What am I thinking? What am I wanting to change right now that I think this substance will do for me? And then sort of the second mindfulness question, are there other ways to get into that mind state, get into that feeling state, getting into what that might do that may be more useful in the short term and long term in my life? Elliot's also bringing up Provigil or Nuvigil as an option for someone who can't tolerate stimulants. So Provigil is modafinil, Nuvigil is armodafinil, the right-handed stereoisomer, and I do have a talk on modafinil. For years it's been called the non-stimulant stimulant, maybe working more strongly on orexin systems. Clearly a substantial amount of evidence showing efficacy for ADHD, although not FDA approved for such. Michael comments on seeing a lot of people identifying themselves as AUDHD. They usually describe it as like being two different people, but isn't ADHD alone being like two different people? Yeah, so again, I'm quite aware there are people who both diagnoses fit, and if so, great. But I also am seeing many people where the addition of one of the labels doesn't seem to particularly add anything informationally. I'll just leave it there. So Makita Rizikov, no apologies for being late. This is a forum for people with ADHD, so late is not a concept we believe in. And asks if there are any safe ADHD medications for a patient with bipolar disorder 1 with a previous history of amphetamine-induced psychosis. So I do have a talk just on amphetamine-induced psychosis. My opinion is that clinically it's one of the most neglected and it's uncommon, but it's really serious. My standard is not to read, that stimulants are off the books for someone who's had a response. And it doesn't mean the second or the first dose you take Adderall again, having had a previous episode, that you're going to get psychotic again. But I think having had even one episode, even years ago, substantially increases the risk. I can bring up the first case I saw was in a person who was on prescription stimulants for more than a year and a half, were extremely helpful in terms of this guy in his 40s. He was able to go back to school, finish a degree, and get a good paying job, and then develop psychosis. And it turned out that he had lied on his intake and had a previous episode years before from street stimulants. So avoid stimulants. So to me, that would lead armodafinil should not theoretically be an increased risk. And I don't think that there's much evidence that that's likely to trigger a manic symptom in bipolar. Guanfacine would be another presumably safe option. Given bipolar, depending or not whether someone's on a mood stabilizer, which theoretically the standard recommendations would be, but something like many of our antidepressants that help with ADHD do have some risk of triggering mania if someone is not already on a mood stabilizer. And in terms of mood stabilizers, I would think Abilify should jump close to the top in terms of being something that can have efficacy for ADHD. Leslie Ladyhawk asks, is Wellbutrin okay? And so I do have a video on Wellbutrin, bupropion for ADHD. When you're asking, is it okay? Like any drug, some people do well, some people don't. It has fewer dangerous risks, so no risk of addiction, no risk of perceptible risk of psychosis compared to the stimulants. Is it going to work for you? That I don't know. So I'm not quite sure what is it okay is referring to. Michael's offering a comment, but I don't see a question. That the hyperactive and inattentive symptoms seem pretty different for him, and yep, they are different. Zelda's saying, sometimes I feel like I cannot control my cannabis use, but the other conceptualization of that experience is that it's a helpful tool for emotional regulation and very helpful for shifting thoughts. Yeah, so I would sort of revert to my mindfulness and sort of evaluating what it seems to be doing. Are there other ways that could help you with emotional regulation? And so I don't know if it's Cato, I guess I should. Ko Espindola, sorry if I'm butchering it, asks, is vortioxetine helpful for ADHD or a good match for Vyvanse ADHD? And this person has ADHD and anxiety. So vortioxetine, again, not Viloxazine, not Qelbree, but vortioxetine, which is Trintellix in the US. It was originally called Brintellix, but there was a hypertensive medicine, I believe, with a name too similar, so they switched to Trintellix. Has weak serotonin reuptake action, has actions on several other serotonin receptors, particularly the serotonin 7 system, and that's considered to be why it has some pro-cognitive, pro-executive function action. My understanding is that there had been research, I have not seen any published, on vortioxetine for ADHD. So there's at least some interest in theoretical grounding that could all be helpful. I've had some clinical experience with people primarily taking it for depression who felt that it did have some benefit. It's not a drug that's been FDA approved in the US for anxiety, but along with many but not all antidepressants, it does seem for many people to help with anxiety. But I've also seen in the first few days or weeks some people increasing anxiety or agitation on it. And if Vyvanse is already part of what someone's taking, the recommendation would be to start low and go slowly and cautiously. And that Vyvanse itself can cut either way, worsening anxiety or improving anxiety. And the ultimate veteran, 89, is agreeing that revisions are needed regarding ADHD diagnoses in the 20th century, yes. So, and I've talked about this one before, but no problem with repeating things. It means that there's lots of interest in the question. So Lady Hawk asks, they're on Wellbutrin and buspirone. So bupropion and buspirone, Wellbutrin and Buspar. For 4 years, how long should Wellbutrin take to work for ADHD? So I've heard many of the experts in the field claim Wellbutrin's an antidepressant. Antidepressants take a long time to work. Therefore, they should take a long time to work for ADHD. Doesn't make any sense at a biochemical level where Wellbutrin has immediate, within minutes to hours, impact boosting norepinephrine and dopamine levels in prefrontal cortex. From that, we would expect it to work quickly. And if you talk to people who take it for ADHD or even are taking it for depression, but notice I'm more alert, I'm more focused, I'm more energetic right away. I don't know if these experts don't talk to people or if they talk to people and don't listen or what's going on. So I would argue strongly, if Wellbutrin's going to help with their ADHD, you will know it right away, meaning the day you're taking it. And so Ultimate Veteran is saying purple champagne, and I guess that's a marijuana strain is what's helping them. Artisan King is asking, what do I think is the best medication for over-methylated ADHD? I'm not quite sure whether that's a typo and they're meaning over-medicated or whether they're talking over-methylated, and there's some evidence that's separate from what your genome is, how many methyl groups you're sticking on different parts of your genetic transcript on your genes, so that it does or doesn't get transcripted is a contributing factor to ADHD. So I just don't have anything to say there. So Max has included the link to the marijuana and ADHD. And also the link to amphetamine-induced psychosis. And Ultimate Veteran is advocating for knowing yourself, and that also, though, that beyond knowing yourself, that changing behavior is what's important. And Max, again, thank you, has brought up the link for Wellbutrin and ADHD. So Mikita Rizikov is referring to the amphetamine-induced psychosis and would never risk using stimulants again. And I'm glad to hear that, because one of the most shocking things to me is that a number of people who have had amphetamine-induced psychosis, and even though classically it's a fairly paranoid state, I have never seen a case where it was truly manic-like, where someone was both enjoying themselves with great hilarity and also having, it's been pervasively paranoid. People are spying on me, my family's poisoning me, people are surveilling me, people are trying to restrict me from doing great and wonderful things. There may be some element of grandiosity occasionally, but it's more in the paranoid. But anyway, what I've seen over and over again is people hiding their history of this, covering it up so they can get on stimulants again. And one of the most profound examples I can share is a guy in his late 20s. He was in the tech world, had a good income. Well, had several good incomes when computer programmers were paid handsomely. I'd argue they still are, but jobs are harder. Anyway, had lost numerous jobs as well and sort of covered up why. And it's because he did have ADHD, did take stimulants, and he would become psychotic, usually within a week or two of getting back on stimulants, but enjoyed that state enough. And his paranoia was his psychosis was quite paranoid. So when I worked with him, which was for a short period, again, gave him inaccurate history. I prescribed for him because it seemed appropriate, and he wound up in the hospital, brought in by police because he was assaulting someone in a bar who he thought was spying on him with his family's collusion, he thought. And from the hospital, when he was calmed down, but still not suitable for release, was calling me, not disclosing he was still in the hospital so that I would write for stimulants again, and had convinced his inpatient psychiatrist, who was just a resident, that because of his ADHD, it was a good idea to get back on the stimulant medication. At least according to him, she was concurring with that. So glad that you don't want to try them again. So we're close to time, and Ultimate Veteran, 2 more. So you're welcome, Lady Hawk. Hopefully the answer I came up with is useful. Ultimate Veterans adding that we're learning more about the endocannabinoid system, that marijuana binds to THC and CBD, and not wanting to bring psilocybin into the conversation. There was a fairly recent study on low-dose psilocybin not finding any benefit for ADHD. And NIAID has tried 5 milligrams dexedrine, but it's way too much, and is using it in a much lower dose of 0.5 milligrams or 1 milligram range. So in my talk on high-dose stimulants, I do address not nearly in as much detail. Just as there are people at the extreme end of needing a bigger dose, there are people who are extremely sensitive, and a variety of factors, including how well we absorb things, how quickly our liver's enzymes break things down, maybe the density of receptors in our brain, also other degradative enzymes all affect. So that's an unusual sensitivity, but it's not unheard of. So Max is thanking everyone for the great questions. So I enjoyed the talk today. I hope you did too. Tune in next week and subscribe to the channel if you don't already. And also Max is putting in a plug for the Reddit page, which is on Reddit under Dr. John Kruse. And I'm glad the connection worked today. So thanks for being here, and have a great week. Stay healthy and happy.